This morning I presented the neoMONARCH study. This is a phase 2 clinical trial in women with early stage hormone receptor positive HER2 negative breast cancer, measuring at least a centimeter. The aim of the study was to evaluate the clinical activity and safety of the combination of abemaciclib, a CDK4/6 inhibitor, in combination with anastrozole. Abemaciclib is a CDK4/6 inhibitor which is given orally on a continuous dosing schedule, which is unique compared to the other CDK4/6 inhibitors. So in this study, patients underwent a baseline core biopsy. They then were randomized to one of 3 treatment arms: anastrozole alone, abemaciclib plus anastrozole, or abemaciclib alone. They received that therapy for 2 weeks and then underwent a second core biopsy, at which point patients then all went on to the combination therapy for 14 more weeks. So all patients had a total of 16 weeks of therapy prior to their last biopsy and then going on to surgery. The endpoint that we looked at was the change in Ki-67 from that pre-treatment baseline sample to the 2-week time point after receiving therapy. What we showed was that the geometric mean change in Ki-67 was statistically significantly greater in the abemaciclib containing arms compared to the anastrozole alone arm. So we're seeing a greater reduction in Ki-67 with the use of abemaciclib. We did meet our primary endpoint because the p-value is less than 0.001. We also showed that there was complete cell cycle arrest in a larger proportion of patients treated with abemaciclib-based therapy compared to anastrozole. The safety profile of the combination of abemaciclib and anastrozole looked to be well tolerated. In this study, we used primary prophylaxis with loperamide to mitigate the diarrhea that's been associated with this combination in the past. Indeed, diarrhea was the most common adverse event that was observed. However, only 4% of patients had grade 3 diarrhea. In addition, neutropenia was only seen at a rate of grade 3-4 in 8% of patients, and that's lower than we see with other CDK4/6 inhibitors, and is likely the reason that we're able to treat patients on a continuous dosing basis, not having to give them a week off every month. So in summary, we're seeing some very interesting molecular evidence of activity of abemaciclib-based therapy in the curative setting. We're also able to do some very interesting molecular analyses on the tumors taken from these patients pre- and post-therapy, evaluating them for evidence of immune infiltration and tumor cell differentiation. We've shown that this combination of therapy is tolerable, and while we can't go home on Monday morning and treat our patients with this therapy, this is providing data that strongly supports the rationale for evaluating this therapy in the curative setting going forward. We've begun to look at tumor samples at the baseline, day 15, and then cycle 5, day 28 time points from patients treated in this study to look at tumor differentiation, or how the tumor is looking more normal like breast tissue as therapy progresses, and also to look at whether or not immune cells are infiltrating the tumor bed. And what we're noticing is, as early as 2 weeks after therapy, regardless of the treatment arm, we're seeing the tumor cells begin to create lobules and normal structures like we would see in normal breast tissue. Moreover, at the cycle 5, day 28 time point, we're beginning to see cytotoxic T cells infiltrate that tumor bed, but not regulatory T cells, which dampen the immune response against the tumor. So this is very early evidence. We haven't done a statistical analysis. We've only done 20 to 30 samples at this time point, but we're hoping in the next 6 to 10 months that we'll be able to share data that has been fully analyzed to explore these endpoints.